right, good evening, everyone. Thanks for joining the presentation today. And then we are going to have a presentation, caring during a pandemic. In today's presentation, you are going to receive a lot of information, and that is going to be beneficial for you and your family. Okay, today's speaker, Dr. Elizabeth Greenlee, is a highly educated, well-qualified, professionally skilled in healthcare quality, consulting, disease management, accreditation, process improvement, infection control, patient, and risk and patient safety. Currently, she is working as the Director of Clinical Effectiveness at Memorial Home and TMC. Also, she is a Joint Commission reviewer. And before that, she used to be the Associate Director for Quality Programs at Harris Health System. That's how I used to know her. Thank you, Peppy, for giving us your time in this weekend. I know your days are very busy during the weekdays. So I'm handing it over to Peppy. Please add anything I missed about yourself.
Thank you, Naini. I must say I miss Naini too. I miss chatting with her every day at work. And when she asked me back in January if I would speak before this group, I was extremely honored. I'd never been asked to speak to a women's group outside of a professional organization or a healthcare setting. And can you hear me?
Yeah.
Okay. So I was saying that I was honored when Naini asked me in January of this year when we worked together to be able to speak to this group. I had never spoken to a group outside of more of a hospital setting or a professional conference setting. And so I was very honored to be able to speak to this group and started planning about talking about professionals, women, and their impact in healthcare. And then the pandemic hit. And of course, that changed everything. Our time together it's not in person, which I had hoped that we would be in person, but I am thrilled still to be able to see faces along the tops of my screen here in this lovely new Zoom world of meetings. So I do have a slide presentation. Let me get it up. Just take me 1 second to pull it up. You never ever thought that we would be meeting like this, did you?
No.
Okay. And I'm used to doing Zoom meetings at work on 2 screens, and so I'm trying to, I've lost like the screen for you guys.
You were able to do it when we did the practice, but
I know. There we go. I shrunk it. Naini, you'll have to let me, it says the host has to disable participant screen share.
Mm-hmm. No, but how did you do it? Eric is the one. My son is the one helping me with all this. So
we all have to have technical advisors. Hello, sir. Are we ready? There we go. Okay.
Got it? Yeah.
Yep. There we go. So you should be able to see 90 thumbs up. Okay, perfect. Excellent. So, as I said, never ever thought we would be in this place having to share things not in person. So wanted to just kind of go through first just some of the pandemics. So what Naini didn't say is that I've been a nurse for 36 years. I've been through a couple of these actually, pandemic, believe it or not. I sort of didn't realize that. It was as much as history would call it over time, but pandemics go all the way back to 430 BC when there was a plague in Athens. The death toll was about 100,000 people, and they thought that it was either Ebola or typhoid fever. Over the years, you'll see there's another Antonio plague in 165 to 180 AD, killing over 5 million people in the Roman Empire. They thought that that was probably smallpox. The Black Death, most of us have all heard about. It was the bubonic plague, and about 60% of the world's population died from that. The very first picture on the left there is a picture from the time in which they started using masks, believe it or not. And so here we are thinking masks are new for folks to wear, but actually, no, it started back in the 1300s. There was a Great Plague in London in 1665, which was, again, bubonic plague, killed about 20% of the population. Actually, the Great Fire of London in 1666 is what eradicated that plague. We had Philadelphia yellow fever in 1793. 1817 was probably the first cholera outbreak. Then we had another plague outbreak in the 1855 time. 1889 to 1890, there was the Russian flu period of time. Then one that most people don't even think about as being an epidemic or a plague was the American polio outbreak in 1916, when there wasn't really anything to take care of it. One of the things that has been published more recently because of where we are today is the 1918 Spanish flu. It estimated that it killed 50 million people. They think that the onset was rather swift, kind of like what we've seen here. They would see secondary infections like pneumonia, and the infected patient might be well in the morning, but then by the evening would be dead. Symptoms from that Spanish flu were very not familiar to the people at the time. They had fever, they had aches, they had congestion, but they had pulmonary hemorrhaging too, delirium, dyspnea, cyanosis. They said that the people's face had a bluish cast to it, which would help them show that they were sick with the virus. This Spanish flu actually killed more young and healthy people, mostly people in their 20s and 30s at the time. And Woodrow Wilson and Franklin Roosevelt, both prior presidents for us, actually had the Spanish flu but survived it. So at the time, was right at World War I time, and most of the skilled nurses in the country were actually across in Europe taking care of soldiers in Europe. And so it was an extremely difficult time here in the United States when we had 80% of our force overseas. And that was probably one of the first recorded nursing shortages that was out there. And it really showed how important public health care planning was because of how widespread this flu bug was. Fast forward a few years, 1957, there was the Asian flu, which had a death toll of about 1.1 million worldwide, with about 116,000 of those here in the United States. Here's where I start remembering things. H1N1, the swine flu. I actually roamed the hallways at the hospital the other day and found a poster that still said, if you feel like you have the flu-like symptoms such as the swine flu, please, cover your mouth and when you cough and sneeze. But that infected 1.4 billion people across the globe and killed probably about 500,000. There's a lot of discrepancy on how many actually that killed. There was Ebola. So we've all lived and heard through Ebola for the last few years. There was then Zika. Zika virus is still very active. The Ebola virus is still very active. And then here comes 2019 and the COVID 2019 pandemic. So far, as I looked at data at the end of last week, 4 million have been confirmed dead. About 150,000 those are 4 million have been confirmed with the virus, 150,000 deaths, which is about a 7.2% death rate. So not as much as some of those in the past, but again, it was one of those viruses that kind of snuck up on us. I found this article where it says, can the healthcare system meet the challenge of the pandemic flu, planning, ethical, and workforce considerations? So reading through some of it, here's some of the quotes from that article. A grim picture is predicted with a significant surge and a need for additional healthcare resources that our nation currently lacks. We're expected to have shortage of healthcare facilities, of equipment, of pharmaceuticals, of personnel. People are able to accept that death is inevitable if there's not a known cure, but how will they feel if the death of a loved one is because we ran out of medical supplies? And nursing and doctors are going to have to work extended shifts, and ICU patients may be moved to other patients for some of the medical surgical procedures will be postponed. So if you read this sounds as if it were written for today. We are seeing these exact same pictures. Our surgical procedures, elective procedures were canceled earlier in the year. We are having shortages of some supplies. Medications used to keep patients sedated when they're on the ventilator are in short demand. And we've had definite equipment issues. If you recall back in New York City, when it first hit New York City, not having enough ventilators and the Ford company going to make ventilators. So you would think that this article was written for today, when in reality, this was first written in 2007, 13 years ago. So we didn't learn a lot from what was predicted at that point in time. Let me give you just a little bit of data. So this map is actually from the Johns Hopkins website. It's open to the public. You can go and look at it if you like. It shows a color by color. With the darker the color, the more infected cases. And you'll see that there is not a single country or nation in the world today that does not have cases of COVID in their communities. Another slide is, this is the daily confirmed cases. You'll see this goes back to February. The United States is in green, and the line, you'll see that sudden spike that we had after Memorial Day, after most cities started to open things back up. You'll see several of the other countries there as well. For local data, we're very fortunate here in the Houston area that the Texas Medical Center has the ability to gather information and has provided a lot of local data. This too is open to the public. If you just type in TMC COVID, it'll be one of the websites that pops up, and they do update this on a daily basis. This one is the average number of new COVID-19 positive cases by week since we started back in March here in the area. And so you'll see that week 17 was our biggest spike. That was the July 13th through the 19th week. And you'll see, though, as we look, that in the 6th week, phase 1, where the governor opened up restaurants back to the 25%, we had been, shut down for the most part through most of that earlier time period. You'll see there wasn't much of an increase in that first wave. But when phase 2 happened, sometime there was a variety of dates where different things opened, May the 18th through the 29th. You'll see again a bump that week. We then had Memorial Day weekend, which everyone was out and about. And after that Memorial Day weekend, you will see that the continuous spike of cases. The good news is that last week that ended on the 26th of July, cases were down. And we are seeing still a downward trend in the community. This chart will show you the number of confirmed positive cases in the greater Houston area. So there's about 6 counties that are included in this area. This is a cumulative total running. So you'll always see that chart increasing. I pulled this actually yesterday afternoon, and it's 98, almost 99,000 people that we have confirmed positive in the area. That does not mean they're sick or in healthcare beds, but they are in a positive patient. Here's our trend. Now this is the daily case by trend, not a cumulative number. And so you'll see again that we have spiked earlier and that we are starting to see some decline, fortunately, in the last few days with our COVID patients. And again, this one is current as of yesterday. One of the things I know is frequently out in the news is there's no PPE, people are re-wearing masks, people don't have masks. This is, again, the Texas Medical Center. So this is more focused just on Texas Children's Hospital, Harris Health, Houston Methodist, MD Anderson, Memorial Hermann, and Texas Children's Hospital. So, and UTMB is included in that one too. So this is those local hospitals there in the Texas Medical Center and the number of supplies. And so you'll see that all are still in the green. However, we're going through almost 10,000 N95 masks on a daily basis and 157,000 surgical masks. If you are in healthcare and still go into a hospital building, you know that you're most likely getting a new mask on a daily basis. So you can see how many people we're going through. Our families get masks as well. So just wanted to turn it away from the data and into a bit more of that caring conversation and what we're seeing. And so one of the things we're seeing is new ways to treat patients. So early on, the message came out, stay at home, don't go out, shelter in place. That has led to telemedicine. And telemedicine was there but it is really very much more active. The federal government released some of the restrictions around using telemedicine after this came into play. And in fact, I've had me and my husband both have had physician appointments via telemedicine, which seemed to go okay. That, the missing piece is not being able to do vital signs or weights, but if it's for basic check-in and checkups, that works quite well. The second thing it led to is drive-by testing. And so years ago, I know that they would do drive-by flu shots, but that was just an arm in and out the door and you were gone. But really, there are more and more drive-by COVID testing sites than you can possibly imagine. They've been set up at the drugstores, drive-throughs like this. Memorial Hermann had set them up in their convenient care centers that they have out and about in the community so that you didn't have to come into a hospital. So many people were afraid to come to a hospital because they were afraid that they would be infected with the COVID-19. The volumes in the emergency departments for non-COVID-19 conditions actually have dropped over the last few months. We have new ways of getting in the hospital. So pretty much anytime you walk in now, you're going to be greeted by somebody that looks like they have isolation gear on. You're going to have your temperature taken. And then it has actually morphed in some places to where it's now thermal scanning. So there's no trying to trust the thermometer. I figured out early on that if I cooled my face off with the air conditioner from the car, my temperature was about 96 when I walked into the hospital. And so it became more trustworthy to see that thermal scanning, and it takes much less time now to have that. Most everybody is asked the screening questions of the signs and symptoms of COVID into a test. And just this last week, many of the hospitals have gone to where it's now an electronic form app on my phone that I go in, I answer the questions, I get a check, I go in, walk past the thermal scanner, get a tag for my name tag that shows the color of the day of what everybody's supposed to be wearing, and then off to work I go. We also have new workflows. So the picture on the left is what most nurses look like now and physicians look like now when they're providing care. They're N95 mask, face shields, always an isolation gown, gloves. Even if it is a non-COVID positive patient, everyone is wearing a general surgical face mask and now either a face shield or goggles. That's the new CDC recommendations. And so you will see many more people, in most everyone, with the minimum of those face shields and goggles. The one thing that really changed too is the IV pumps staying out in the hallway. So in the critical care areas, these are extremely sick patients. And for the nurse to have to put on the isolation garb and go in and out of the room multiple times in an hour sometime was burning through the PPE. And so all across the country, critical care nurses started having their IV poles outside of the patient rooms and being able to use and monitor those, change the bags from outside the room without having to go into the patient care area. This made me a little nervous at first. I have an infection prevention background. I was afraid of, tubing draping on the floor, but they've actually been able to invent some other ways to keep that tubing off the floor and keep it safe. I've seen ICUs to where all the doors are glass doors. They've turned those into communication boards. Since we have no family and no visitors in the hospital anymore, there's a little less concern over HIPAA privacy because it's mostly just the healthcare providers in that area. And so they will use the glass door, like a whiteboard, as a communication board to be able to understand what drip is going for the patient, where they are. And so that's, again, some more inventive ways to taking care of patients in this new time that we live in. We developed a lot of new processes. Duke University back east actually started this first. Memorial Hermann does it. I know for the Harris Health System as well as Memorial Hermann, N95 masks are now being reprocessed. And this is how it looks. They are hung on one of the wire carts that you never ever would thought was used for anything other than storage. They have BioQuil, which is a disinfectant that's sprayed. They're allowed to dry. One of the things with this new process, it works well. We can reprocess a mask about 10 times. However, anytime you see the mask start to have fraying around the elastic bands, it's discarded. Or if the person putting it on is not getting a good seal, it should be discarded. One of the things we find, though, is that makeup or even just your perspiration from your face will cause these to be visually stained. And they work well, but they'll continue to work, but they just look ugly. So those are actually being retained for the what if we completely run out of the N95 mask. We would have some that would look really good, but would still be effective in protecting our staff members. And then we have new ways of meeting, just like we're meeting. And so just a little fun, I don't know how many Zoom meetings you all attend. I would say all of mine are now in Zoom, and they're 4 or 5 a day. And I can tell you in every single one of them, at least once or twice, you hear the unmute yourself. I can't hear you. We even did it here. Unmute yourself. Press *6. Someone doesn't turn on their video camera. We do encourage the video cameras to be on only for that contact feeling, instead of feeling like you're just sitting in a room by yourself. So it is challenging. I would say that we have a daily safety huddle at 8:30 every morning. And so Monday through Friday, my screen is on, but Saturdays and Sundays, I am not camera ready at 8:30 in the morning. So I do not turn on the camera for the weekends. Pretty much most everybody, except for the men, leave the camera off. So just changes that you never thought you would be doing at 6 months, 8 months ago. Just a couple of things from a clinical perspective, signs and symptoms for COVID. I think probably we all know this by heart. The one that came out was really that loss of taste or smell. And so one of the things that I have a friend of mine that says, if there's a stinky fart in the room, that's a good sign, because you're smelling it and that means you don't have COVID. So don't always think that some things are bad. There are definitely severities, illness of severities, and depending on how mild your symptoms are, it depends on how sick you get in the long run. Those critical patients do really get respiratory failure. They get multi-organ dysfunction. They develop shock. They are intubated for quite a long time. The age, of course, the older you are with this disease, it raises your risk factors for the severity of illness. There are some children that we do see. However, it's mostly in that older adult with comorbidities. Diagnosis, of course, the diagnosis is the testing. We do viral testing. I don't know if anybody has been tested yet or not, but that is interesting. I was actually tested both for antigens and the virus itself. Both came back negative, which was a good sign. Lab testing for somebody that actually has it, what they're seeing is very low white count cells. D-dimer clotting factors are elevated. From a radiology perspective, the chest x-ray is showing some consolidation, but many of the patients who are positive have normal looking films. You would never know. The same with CT scans. Many are normal in the very first stages of the disease, but then as time goes on, they have ground glass opacities, which we hear about. Remdesivir is the new medicine that seems to be one of the most effective. It is an investigational drug, and when we first started with it, it was allotted only by the government as to what organizations they felt could have it. It has, for the last couple of weeks now, been to where organizations can buy it. It is very expensive. It's a couple of $1 million for around 100 to 200 doses. So it is not a cheap drug. Convalescent plasma is really quite interesting. I know in the media it looks like Methodist was the only hospital that was doing that. That's not true. There are other hospitals that are giving convalescent plasma. So anyone who has had a positive COVID-19 test, they're able to go in and they are able to donate their plasma, and then the plasma or their blood, and the plasma is pulled out and it's being given to patients. It too is showing great success rates for helping to patients get well better. They're not going to do a COVID test on you, but about 2 weeks ago, the blood banks actually started just testing all blood that was donated to see if they had any COVID-19 virus in the system, and if they were being able to pull out the plasma to give for patients, which is, I think, rather exciting to say that we're able to go through it. You have to be at least 18 in good health, not have any current flu symptoms, and then have a positive COVID test to be able to donate. You should have to be, if you've had COVID, they want you to be at least 14 days symptom-free before you go donate as well. Mechanical ventilation, again, for the sickest of the sick, we're seeing this. Many are also going on ECMO, that extracorporeal membrane oxygenation. It's basically life support machine. And, we've seen it in the past. It actually started out in the children population and then morphed a lot into the cardiac and then the medical world. We are frequently seeing it on the sickest of the sick patients here. Proning, turning the patient face down when they're even when they're not ventilated. If you feel like you might have symptoms, you get better oxygenation laying on your stomach. But we have proning teams in the community healthcare settings now, so that they go out and they actually will turn the patients, and their oxygenation improves dramatically. One of the things that's being seen, however, with proning is that patients are developing pressure injuries on those bony prominences. When we first started doing that, there was not a lot of padding or thought put to protecting those bony prominences. We have a friend of ours who's been in the ICU. He's on his 6th week in critical care now and actually able to start doing better. But the warning came to the wife before they would let him FaceTime with her, was that his face looked terrible because of the pressure injuries that he had developed. Anticoagulation therapy, that is kind of the one difference for this than other flus, is patients clot a lot. So you're seeing strokes afterwards. While they're sick with the COVID, they're actually seeing strokes as well. So really making sure that we keep patients extremely anticoagulated with thin blood during this time. Preventative guidelines, you hear it every day. Hand hygiene, cover your cough or your sneeze, wear the mask, keep socially distanced. That is, I think, what we'll have on most people's memory books for the year. Those are the things we needed to do. This, because everybody always talks about how long does it live on surfaces? What do I need to do? So this was actually published a little earlier this year. And what it shows is that basically everything after 3 hours goes away. The only thing that stays is on hard surfaces for longer period of times is really the plastic, and that's low numbers, right? So the other thing then that is the question that, didn't have the slide. The other question that's always asked is, what do I do to clean it? What do I do to get rid of it? And basically, household cleaners, general household cleaners work. So your bleach wipes, your alcohol-based wipes, any of those will work. And in fact, after 5 minutes with those kind of wipes or cleaning products, there's no virus that can be found on surfaces. So just make sure that you're wiping down and cleaning those high touch points. So we've actually been in this as a country for 7 months, Houston for a little longer. And so some of the things that we've learned is we definitely know that it's spread person to person through droplets. It's not airborne, so it's not hanging out in the air. And if you walk through an open area outside, you're not going to catch it if somebody else has been through there. It is just truly those droplets. When someone coughs or sneezes or speaks loudly and has droplets of air flying out of their mouth. My high school English teacher had that. She had the droplets of sputum would go, and so we never ever sat close to the front row because we knew that she would spray us. That's how you're going to catch this. There's anywhere from a 2 to a 14-day incubation period. Mortality, again, is associated with the older patient and who has more comorbidities or health issues. There are racial disparities. I think a lot of that has to do with the ability of cleaning supplies and how close some people live together when they don't have individual homes or the ability to clean their homes. Maximum of 2 days on any environmental surface for survival. What the long-term shedding means that if you were tested for COVID, that is going to be in your system for a while, but you won't be infectious beyond 10 days. So most recently, the CDC changed their recommendations for people returning to work after they've been sick, and it is because of this. Because you're going to keep having positive tests for COVID if you've been sick, but you're not going to get anybody else sick after that 10-day period. And again, common disinfectants, just wipe things down. Some of the unknowns over this last 7 months is we really don't know how many cases there are across the country. And then we do know that there's severe disease predictors. We don't know what severe disease prediction looks like, so how sick people are going to get from this. And then there's not a lot of research, yes, on how contagious it is before someone has no symptoms or they have minimal symptoms. And so those are things that our researchers will still work on. Then caring for others. So I know as women, most all of us care for others in our lives. And so there's a lot of things. This may be someone in your home or someone that you know that's elderly. Just make sure we cover those basic needs. Do they need help with groceries? Do they need help fixing meals? Don't forget about people's pets, especially if they've been sick. We sometimes it's ill, but we forget that they may have a little loved one fur baby sitting there that needs some care as well. From a medical perspective, make sure that you are isolated from a person that's sick. Try to keep the windows open. So way back in the 1800s, Florence Nightingale realized that fresh air was critical to healing in the soldiers in the Crimean War. The same is still true today. Fresh air and air circulation help. But keep that bedroom door or the whatever room they're in, keep that door closed so they're not, again, they're a bit more isolated and not sending out any germs throughout the whole house. Don't share personal items. Clean and disinfect those high-touch surfaces, the refrigerator doors, the sink handles, all of those places where people will frequently touch. Have a thermometer and take your temperature. Keep a record of it because you'll forget. Trust me, you'll forget. I can take mine and 10 minutes later have forgotten what it was. Make sure to drink fluids, just like any flu virus, drink a lot of fluids. Alcohol is not good during this time. Take regular Tylenol for the fever. Take a sponge bath. I know it's old-fashioned, but still a sponge bath will help to reduce those fevers. And most importantly, I'll say it again, wash your hands after you've provided care for someone. So talking with your kids. So this is important because I will say, I just had my hair done earlier this afternoon, and the lady that did my hair said her 3-year-old is scared to go outside because of what he hears on the TV. And so when you need to talk to your children, stay calm about it. Don't act as if it's the end of the world. Be reassuring them, let them know they're safe. Make sure that you're monitoring what they watch on the TV or the internet. All the stories that are out there can be extremely scary in general, not just related to the COVID, but anything these days almost it seems like it can be scary on the TV. And then teach them how to avoid spreading germs. Teach them to wash their hands. Nini and I worked with an infection control nurse that her daughter at the age of 3 was teaching other people how to wash their hands in preschool. And so you can start at a very young age teaching little ones how to not spread germs, teach them to cover their cough and to wash their hands. One of the other questions that's come up is about school opening. From a county perspective, what they're going to be looking at is there needs to be 14 days of decreasing numbers of positive cases, decreasing the percent of positivity of the community, decreasing hospital admissions related to COVID, and then a restoration of our critical cares back to a normal capacity so that we are able to take care of other kinds of patients in the critical care area. And now let's talk about us. So how do we take care of ourselves? So we have to be resilient. Resilient is being able to withstand or recover quickly from different conditions. So how do you build your resilience? There's several different ways. One of them is building relationships. Meetings like this evening is key. Even though we can't be there in person to talk and to give a hug or to give a handshake to, it's really important that you focus on building those relationships with people that you can trust, people that you know are understanding. The other thing is to think about wellness, not gloom and doom. Think about taking care of yourself, good nutrition, good exercise. Not my favorite thing, but I get exercise walking to and from my car at work. That's my excuse. Practice being mindful. Meditate or pray. Think about a journal or writing letters. One of the things that I started doing is I have a cousin in Florida that I haven't seen probably since my first or second year of college, and I've started writing letters to her. And she writes back every single week. And so we've started that little pen pal relationship. Try to avoid negative influences. Limit your time on TV, Facebook, the internet, all of those things that are negative. I had a nurse one time that worked with me that asked me how I could be so upbeat and positive all of the time. And I said, I choose to be. There were things in our life that I could say, oh, woe is me. I have a new mortgage. I'll never get out from under it. The positive side of that was I have a brand new house and it's mine, and I've never owned a house before. So think about avoiding negative thoughts and keeping positive thoughts. Think about having a purpose, something to do, help others, set goals and move forward with them, even if it's small steps forward. Think about cleaning out a junk drawer for today, and then instead of trying to declutter the whole house. Decluttering the whole house will just make me go back to bed and watch TV and a Hallmark movie for the rest of the day, right? And if you need, get help. It's important to understand that this is one of the most bizarre times in our entire lives that any of us have ever lived through. And it's a change. We have to learn to accept that fact, but we also need to make sure that if we need help, we can get help. There's professionals out there. If you have someone that you love or trust that you want to talk to, that's great. But if you need help, there's also disaster hotlines to be able to talk. And this is truly one of those disasters. I know most of the time, especially here in Houston, we think of the hurricane that's coming as the disaster, but we are still in disaster mode with this. Emergency command centers are up in all hospitals. So that is, the federal government is not allowing regulatory agencies to come in unless it's truly an emergency, because we're in disaster time frame. So please, if you need help, seek help. And so with that, let me just remind you of a couple of things. Keep calm and wash your hands. Make sure that you focus on your thumbs, the backs of your hands, the wrists, between your fingers. This is really easy to teach your kids. Make sure you wear a mask. This one's probably not the best out there for a mask. That antivirus mask is not going to help that Karen very much. Make sure that you stay socially distanced, 6 foot away from each other, unless it's someone that you know in your family. Here's the other way we can do social distancing. We can stay away. And last and most importantly, make sure that you take care of yourself so that you can take care of others. And with that, if there are questions, I'm happy to answer any and all questions that you may have.
Hi, the platform is open for asking questions. So if anybody has any questions, please do feel free to ask questions to Pepe. And there are 2 questions in the chat box for you. No, there actually it is not questions. If anybody has any questions, please feel free to ask her.
So the chat works well if you're able to do that, or if you, I don't know if you've unmuted everybody.
Yeah, I have a question.
Yes, ma'am.
What are the chances of a reinfection?
So what the research has shown so far is that reinfection is rare. Most of the time what has happened is that the patient has not really recovered completely, but the likelihood of reinfection at this time is rare.
Okay, thank you, Pepe. All right, so how is the mortality rate is getting reduced in Houston when compared to the other states?
Our mortality rate here in Houston is much less than what it was, say, in the New York area. Again, I think that one of the benefits we had here in the Houston area is that the disease really came in on the East Coast and the West Coast. There's an organization in California that I used to work at that had some of the very first cases in California. They had a fairly significant mortality rate. New York City, we know, had a significant mortality rate. So I think a couple of things. One, the population is so dense in New York helped to contribute that lack of social distancing. But 2, I think that we here in Houston had the ability to be prepared. So by the time that the spike really hit, we were all masking and going to the hospital. Visitors had been restricted from the hospitals. And so I think that has helped keep our mortality rate down. I think the most recent mortality rate, we are around 12% for this disease as the Houston community. And I saw another one come in. The status of the vaccine availability. So there are some clinical research trials on the vaccine, the first round of vaccines. They are having human testing already. I will say from a perspective of the entire community vaccinations, probably not until the spring or summer of next year.
Okay.
I have one more question. The antibody testing, like, is it there? Are we like checking the antibodies now?
Yes, well, it depends on where you are. There's kind of a couple of different testing. There's the one that's just like the nasal swab that just checks for presence, but then there is a antibody testing. And if you think that you've had it in the past, the antibody testing is going to be the way to actually identify it. Rapid testing is more just for presence or negative for the virus being in your system.
Right.
And there is another question in the chat box. Okay.
So do you think the doctor can check for antibody even if you're not positive? So they'll check for antibodies, but if you're not positive, the test result will come back negative.
Anyone has any other questions? All right then, Pepe. Thank you so much for doing this presentation for us. And it was really wonderful. And then so much information was provided to us in this presentation. Thanks from the bottom of the heart. And this is done. This actually have done for the women in my community. So I hope they, it is useful for them. Usually the woman does everything for the families, of course. Their life always goes to the family. Okay. Thank you all. Thanks everyone for joining, finding your time, and be part of this presentation.